Hello, everyone. It is my pleasure to welcome you to the March edition of the Camera Mentorship Program called Own Your Future Seminar Series. Today, we are blessed to have Dr. Dominic LaBella, a radiation oncology resident at the Duke University Medical Center, to talk to us today on the topic harnessing AI for brain tumor imaging, building data sets, training models, and transforming radiology, radiation oncology, and neuroradiology practices. Dr. Dominic LaBella is a radiation oncology resident physician at Duke University, specializing in artificial intelligence application in medical imaging and radiation therapy. His research focuses on advanced computer vision techniques, particularly in developing automated contouring algorithms to enhance clinical precision and workflow efficiency. Dr. Labella actively contributes to international automated segmentation challenges, including serving as an organizer for the Brain Tumor Segmentation BRAT initiative. Specifically, he led the BRAT meningioma and radiotherapy challenge. Without further ado, I would like to invite Dr. Dominic Labella to kindly confirm if he is able to share his screen. And from there, we would like to listen to your talk for today.
Yeah, absolutely. Thanks
Yeah.
you, Maruf. Appreciate the introduction, and thanks everyone for having me. Let me share my screen now. Can you guys see my slides?
Yeah.
Wonderful.
Copy that.
All good? Position. So like Maruf was saying, my name is Dominic LaBella. I'm a radiation oncology resident at Duke University in North Carolina, and today I'm going to be talking about how we harness AI for brain tumor imaging, specifically focusing on how we build data sets, train models, and how it is applied in both radiation oncology and neuroradiology practice. I'm from North Carolina. It's a state in eastern United States, in a town called Durham, which is near Raleigh. Duke University is the institution that I work at. This is our big chapel, and then this is our cancer center up on the right corner. I work with the BRATS organization. It's a large international group that hosts challenges each year, mostly focused on segmentation of different pathology, gliomas, sub-Saharan African patient population gliomas, pediatric tumors, meningiomas, brain metastases. And in the last 2 years, we've expanded these segmentation challenges to also incorporate some generalizability challenges, image synthesis, in painting, and it's a pretty fun group to work with. We present our findings at the Mackay conference each year. Today we're going to be talking about initially an overview of AI applications in neuroradiology and radiation oncology, moving into kind of an overview of radiation oncology field and automated segmentation. Then we'll talk about how to build data sets well for automated segmentation development, do a brief overview of some of the mathematics behind a deep convolutional neural network, and some of the different automated segmentation challenges that exist out there and how you can get involved and participate them as a participant and organizer if you want. So to start off, we'll talk about the applications in neuroradiology and radiation oncology. Primarily, there's a couple different applications. The one that I work the most with is going to be automated segmentation and contouring. I'm going to focus mostly on that today. There's also automated classification, assisting image interpretation, image enhancement, automated exam protocoling, clinical predictions, and these are just a few of the many, many applications that have been developing over the last few years. AI in medicine and neuroradiology is an extremely expanding field right now, and there's a lot of research publications on it, a lot of different labs working in it. So it's something that continues to grow every day over these past few years. Auto contouring in neuroradiology is something that's been around for about 15, 20 years now. The BRATS organization started a little over 10 years ago, and this year we're hosting a cluster of challenges that includes 6 different segmentation challenges, pre and post-op gliomas, preoperative meningiomas, meningioma radiotherapy planning, pre-post treatment brain metastases, glioma in the sub-Saharan African patient population, pediatric brain tumor segmentation, and then some other examples of contouring neuroradiology. Last year, I participated in the Circle of Willis TopCal Automated Segmentation Challenge. And I'm also part of the FETS organization, which is a Federated Tumor Segmentation group, which is a different type of model structure that I'll get into in a little bit. For an example of what pre and post glioma automated segmentation looks like is going to be shown in these figures. You can see a multimodal, multi-label image with label pairs. And here we see the yellow represents resection cavity, the blue is representing enhancing tumor, the red is necrosis, and the green is surrounding flare hyperintensity representing edema or gliosis. The Bratz meningioma preoperative data set was a challenge in 2023, where we had enhancing tumors, non-enhancing tumor cores, and the surrounding flare hyperintensity on multimodal imaging, including the T1, T1 contrast, flare, and T2. The Bratz radiotherapy meningioma planning series was the first radiation planning focused automated segmentation challenge, and that was hosted in 2024. And this one was a single modal, single labels data set where we only had post-contrast 3D native resolution images paired with the gross tumor volumes for each of the patients that had meningioma that underwent radiation treatment. And this was the first radiation planning challenge the Bratz organization did. They had the pre and post operative brain metastases challenge, hosted primarily by Marion Aboyan and her team. They had enhancing tumor here in yellow, the necrotic tumor in red, the green surrounding flare hyperintensity, and they also have resection cavities in this year's 2025 challenge. The glioma in sub-Saharan Africa patient challenge hosted by Odona and Maroof is going to also include the surrounding non-enhancing flare, enhancing tumor, non-enhancing tumor on different machines that we have seen in the primary pre and post glioma data set. And the purpose of this challenge is to try and have a model that generalizes to different MRI scanners that might not have the resolution and a different patient population that may have more advanced disease than that seen in the other data sets. This also was the multimodal, multi-label data set with the different series. The last segmentation challenge for Bratz in the past years is with pediatric brain tumor segmentation, which had primarily DIPGs for pediatric patients. And yeah. Circle of Willis is a different type of auto-contouring structure that we look into. I participated in this challenge last year, and this is an example of one of the Circle of Willis's cases where there was a lesion preventing all of the Circle of Willis from enhancing on the imaging, and this was just another example I wanted to show you. FETS is a organization that works in federated tumor segmentation. What federated tumor segmentation is when you incorporate data from many different institutions in an anonymized manner, along with training from all of the different institutions in an anonymized manner to allow for generation of very large data sets. The original FETS project back in 2022, published then, included 71 institutions worth of data for over 6,300 patients, all with glioblastoma. And the training process for this study was by building one model that performed very well on all of the trained data compared to a baseline that just had one public initial model for the pre-training. And you can see when the federated model was conducted, they had a significant gain in the dice similarity coefficient, which is one of the common metrics we use. I'll get to in a little bit, but it's a very progressive type of model training that I think is going to be done a lot more in the future. We are doing the FETS 2.0 study right now, which is a post-operative segmentation of treated glioblastoma data set. We created an initial federated model back in December and January, and we're going to be presenting the results of that initial model at ASNR this year. If you want to come by and see our presentation, it's going to be Monday, May 19th at 9:50 a.m. And the figure on the left shows how MedPerf, which is one of the organizations, AI companies we're working with, kind of distributes the data and the model parameters from each of the different contributing institutions and performs their training process, where each of the weights are updated locally at each institution before they're sent back to the central model aggregator during each of the training rounds. We'll get into a little bit about the training process later on. The image on the right is just an example of the post-op glioblastoma with the skull stripping, as you can see on the periphery. We did have, I think, initially 28 training institutions, but we had 53 total participating institutions contribute data, and we're going to be rerunning this training process over the next couple weeks and months before May to generate a final model for publication. Some other applications in neuroradiology of artificial intelligence is going to be automated classification, where a AI model can help with your differential diagnoses depending on the image that it's looking at, give you certain probability functions for what image or pathology you could be looking at. There's multimodal input and output applications where you can have images and clinical data and maybe oligoclonal bands from electrophoresis all in the input. And each of these different contributing factors is going to help you make some multi-output application where here you can have a lesion detection outlining where a potential lesion is, and you can also make diagnoses. And this is just one example of how AI is not very limited to just one specific use case. Depending on your data, you can have multiple use cases and outputs with a given data. MR image synthesis is another broad challenge that was done in the last 2 years, where you have a input potentially of just 2 or 3 series. There might be something missing, and based on the missing modality, you can try and generate the missing modality. So you're artificially creating image series. This is also used a lot in the radiation oncology world, where we may have a planning MRI scan, but in radiation, we often will use CT scans to actually create the radiation plan, calculate all the absorption of the photons going through the body. And by artificially generating a CT scan, it allows us to perform the calculations we need to, where we are using the anatomy from the MRI scan to actually develop our contours for that plan. So this is a pretty important project as well. Next, we're going to talk about kind of just an overview of radiation oncology, what I specialize in, and a little more about automated segmentation and its use cases. Radiation oncology is something that's been used for over 100 years to treat patients. Originally was used by Mary Curie with some skin cancer lesions. About 50% of all patients that have cancer are going to receive radiation therapy at some point during their treatment course, and we treat both adult and pediatric patients. We have 2 different major functions for cancer patients. One is to cure them, definitive intent. We also have patients that we palliate when it's not a curative case, but we try to provide symptom relief, pain relief. And I want to mention we also do have non-oncologic use cases for radiation, sometimes keloid scars, AVMs, trigeminal neuralgia, scleroderma. There's a lot of different pathology that responds really well to radiation, even though it's non-cancerous. And a lot of that is just due to the kind of the cellular structure and makeup and how these different fibroblasts respond well to lower doses of radiation. Trigeminal neuralgia is a special case where it's the highest dose of radiation that we give for anything, where we give up to 90 to 100 gray at a very small pinpoint location with the purpose of just ablating that trigeminal nerve to eliminate any of that neuralgia pain. Radiation's delivered primarily with 2 modalities, external beam radiation or brachytherapy. External beam radiation is from a distance from a gantry, usually with photons, electrons, sometimes protons. There's a few centers in the world that do carbon ion therapy or different heavy ions. Brachytherapy is a type of radiation treatment where you are implanting a seed or radioactive source into the body, and that's going to either be left there permanently in cases of low dose radiation, or sometimes it's just going to be there for a couple hours or a couple minutes when you use high dose radiation. And this allows you to have, better dose distribution to limit the amount of radiation going to the normal organs to try and limit toxicity. Radiation can be given in three primary settings. The first one's going to be neoadjuvant before some definitive form of treatment, primarily being surgery. Sometimes we combine radiation with chemotherapy, and the purpose of doing so is often to use chemo as a radiosensitizer to enhance the effectiveness of the radiation. We sometimes have adjuvant radiation after surgery, like post-op radiation for breast cancer or for glioblastoma, with the purpose of trying to cure the patient of any microscopic cells that could have spread locally, regionally in the area, to give them better long-term outcomes for both local, regional, and distant control. We also provide definitive chemoradiation or radiation alone as curative treatment. This is typically done with, head and neck cancer, prostate cancer monotherapy, meningioma radiotherapy, monoradiotherapy. Then pretty much any different type of solid tumor in the body can be treated with some sort of curative intent definitive radiation. The way in clinic we treat radiation patients is first having a consultation either in the inpatient or outpatient setting once they are diagnosed with some form of cancer or non-pathologic disease. After we see them in consultation, we do a CT simulation planning scan, or some institutions do MRI simulation scans in recent days. This is going to be a specific CT scan that's calibrated to our radiation linear accelerator or proton machines that allows us to actually calculate the radiation dose going through the body in the exact same position they're going to be treated in. And it allows them to be reproduced and set up properly so we know they can fit in the radiation machine. Radiation planning's on the time scale from minutes now to a couple weeks, depending on the technique used. And it's typically given either 1 to 5 days a week, depending on the fractionation scheme we use. And patients see the primary radiation oncologist each week to address any side effects that they could be experiencing. Tissue diagnosis is very important. Diagnostic imaging is very important. We often fuse different scans like MRI or PET imaging with our planning CT simulation scans to help delineate tumor volumes. And we have to work with a lot of different other team members. The CT simulation, MRI simulation scan is the blueprint for the treatment. It's a very high quality diagnostic near level CT or imaging in the treatment position. And we often use immobilization devices to hold the patient with, 1 to 3 millimeter margin of error movement for reproducibility during treatments. And we sometimes use 4D imaging to assess for any motion that could happen, such as with patients undergoing lung cancer treatment, to reduce the amount of intrafraction motion to ensure we hit the tumor each time. These are examples of some of the different immobilization devices we use. In the top left is a mask that's primarily used for brain treatments at Duke. And in the top right and the bottom is going to be different setups for either lung cancer treatment or a belly board for abdominal treatments. The radiation planning process nowadays is very computer optimized, very personalized for the anatomy of each patient. There's a lot of quality assurance that's done to make sure that the plan we develop is actually delivered appropriately in the patient. And our ultimate goal is to try and maximize the dose to the tumor to a reasonable level that's been shown to be effective in prior literature, while minimizing the dose to all the normal tissues. We often set constraints, which are going to be tolerable dose levels for each of the different structures in the body, and making sure that they are not significantly exceeded to reduce the, grade 3 or above adverse effects that might occur after treatment. This is an example of a linear accelerator that would be used at Duke. It delivers photons or electrons to patients, and photons completely penetrate from one side to the other, whereas the electrons only penetrate a few centimeters into the body for superficial tumors, skin cancers. Multi-leaf collimators are these metal blocks that can move during the actual treatment, either blocking the target volumes itself or shaping itself into the target volume shape before the beam is delivered. And the purpose of this is to try and craft an optimal dose cloud field to make sure that we are delivering the right amount of radiation to the tumor and minimizing the radiation dose to all the normal organ at risk structures that would be blocked by these multi-leaf collimators. This is an example of a 2D treatment plan where there was no 3D simulation done, but instead we are just having the patient lie down on the table. We'll craft the multi-leaf collimator blocks just based on a setup port image, and that way we can do a very quick treatment with not a whole lot of precision in terms of dose sparing of the normal structures, but we can make sure we hit the target we need to hit in, very severe emergent cases, whether it be spinal cord compression, SVC syndrome, significant pain, things like that. More commonly, we do 3D treatments where we are going to identify the tissue in the body that we want to treat and prevent with that CT simulation scan. 3D means that we are not going to be having a lot of these multi-leaf collimators moving in and out throughout the treatment course, but it's usually just a static multi-leaf collimator, and you have a pre-planned shape from each of your beams. These beams usually are ranged in the numbers from 1, sometimes up to 7. After we exceed that amount, we typically get into something called IMRT, which is a more complicated computer-based planning. These 3D treatments are often manually created in terms of the beam shape and dose and energy levels. This is an example of a 3D case with multiple beams that you can see in each of these views, and they're delivering these isodose lines, which represent the amount of dose relative to the prescription dose, which is in yellow, kind of hard to see on the periphery here. And this is kind of what a final radiation plan looks like in our world. IMRT, intensity modulated radiation therapy, or VMAT, volumetric modulated arc therapy, are two different techniques that are used to give a high amount of dose to a very small target area. And it includes the multi-leaf collimators blocking your targets as they are either staying in the same spot or this arc of the gantry radiation beam rotates around the patient. It's very computer optimized. Humans can't manually perform these calculations to anticipate where the multi-leaf collimators are at every point in space. And it's something that's been used about 15, 20 years now, quite extensively. It takes a lot longer to plan, sometimes 1 to 2 weeks. So this is used for more curative cases that can wait a few extra days to try to make the best plan possible. This is an example of some of the arcs, beams across each of the arc angles and the multi-leaf collimators at each of those respective locations, and how the target volume in red is going to be receiving that dose while everything else can kind of get blocked out as this gantry moves in this arc fashion. This is going to be an example of IMRT or VMAT dose distribution, where you can see that the fall off dose around the central yellow is much more like a sharp drop off, and there's very limited amount of dose going to the liver, going to the heart, going to the lungs, compared to what would be done in a 3D treatment, where you just have those open beams coming from the front or the back or the side, which would give a lot more radiation to the liver, lungs, and heart. This volumetric radiation treatment really allows the shape of the beam to be crafted to just give the radiation dose to the esophagus like we see here. This is an example of arc therapy for a liver tumor. You can see that it's a very conformal small target, and the arc therapy allows for this as well. So how do we develop these 3D and IMRT plans? It's going to be with contours and constraints. That's going to be kind of the one big focus for this talk, is going to be contouring. Contouring in radiation oncology involves creating volumes in the 3D image realm for your targets. Gross tumor volume is going to be the definition we use for any gross residual disease after surgery or potentially an intact meningioma, whatever the cancer that's still macroscopic is on that simulation imaging. We also contour all the normal structures, which we call organs at risk. And these are going to include important structures depending on the part of the body we're in. For the brain, The most important structures we want to limit dose to are going to be the brainstem, the optic chiasm, the optic nerve, the lens, the retina, the temporal lobes, hippocampus, and each of these different structures have specific constraints in terms of how much dose they can get across a certain number of fractions or treatments. And this has been studied extensively over many decades, and we can kind of fine tune our plan to approach these constraints without exceeding them while maintaining a high dose to our target volumes. The higher dose for one fraction is something called stereotactic radiosurgery, and this is going to be used primarily for like brain metastases, sometimes for meningiomas, for trigeminal neuralgia. And by giving a very high dose in one fraction, we can call it a stereotactic radiosurgery, get the patient done in one day. Since it is a longer process with a lot of setup imaging, a lot of quality assurance, they're in this tight head frame. And it also sometimes can provide oncologic advantage as well. When we do fractionated courses or hypofractionated courses or ultra hypofractionated courses, what that means is it's going to be more than one fraction or dose of treatment, and it's going to be a smaller dose each day across many days or weeks. And by fractionating your total dose, it allows the normal tissue to heal between treatment each day and allow the tumor to not heal. So how does AI play a role in contouring? And that's going to be with automation. This is an example of what we call total segmentator, which is a open auto contouring model you can find online that does over 100 different labels all in one model, and it can be run in just a few seconds. On the right is a company called Brain Lab, which provides models for the brain for target delineation of metastases. It also automates the organ at risk segmentation. And this Brain Lab tool is something that is often used in clinics to speed up the process for contouring, which can take many minutes to hours. So why is contouring automated nowadays? Mostly time efficiency. There's an argument that it could be clinically better than humans because humans get tired and they may make mistakes. The opportunity cost is important because for every minute you spend contouring, that's a minute you're not doing something else, whether it be research, seeing patients, whatever. So one study showed that for head and neck patients, there's 42 different normal organ at risk structures that are required to be segmented. And the amount of time is going to be 106 minutes when you're doing this manually. One of the models used could be done instantaneous, and then the amount of manual corrections of those automated segmentations can be done in about 10 minutes. So for each patient, if you use the auto contouring to assist the radiation oncologist in finalizing their structures, it saves about an hour and a half per patient, which is a lot of time. Head and neck traditionally takes the longest to contour due to the many structures needed. Another thing is that automated contouring has very little amount of correction needed for most of the modern day models. One study showed that 98% of predictions needed very minor or no revisions at all to reach clinical acceptance by the practitioner. Mean inference time for automated contouring is very quick nowadays. One model called RTPNet can achieve prediction of your targets in less than half a second. So the technology nowadays has come very far. Computationally, it's not as expensive as it used to be, and it's very effective. Adaptive replanning is something used in the radiation oncology world where a patient comes in for treatment and they actually have repeat contouring done every single day on the treatment table. And then a new AI-driven treatment plan is made instantaneously. And the provider can choose between this initial plan based on the new daily anatomy versus the initial plan that was made 2 weeks ago. And due to some anatomy shift, these new adaptive plans often reduce the amount of dose going to the normal structures, reduce toxicity. It's a big area of research. So next I want to talk about how to build data sets for automated segmentation development. If that's something you're interested in doing, I think it's going to be a big part of the radiology world over these next few years and something that I think everyone should be familiar with. We'll also talk about training a little bit. So key points when you're building data sets is what kind of data you need to obtain, kind of how you set the annotation workflow and protocols up place, and then legal considerations. A few data sets we're going to run through are going to be the BROTS challenges, total segmentator, like we mentioned earlier, and the RTP data set, which is also a very prominent one that works well. One paper I want to talk about is from our challenge last year, the preoperative meningioma data set, which included multi-image, multi-label data. Multi-image, multi-sequence, multimodal are kind of interchangeable, but that means that in your input for your model, you have 4 different sequences of imaging that all are contributing data to help you predict multiple labels. In our case here, we have 3 different labels: the blue enhancing tumor, the red necrotic tumor, and the green is surrounding non-enhancing flare hyperintensity signal. These different types of data are important to note when you are building these data sets. So single modal means you just have one image type, whether it be CT, one series of MRI, sometimes PET. Multimodal is going to be when you incorporate multiple imaging modalities to help improve that imaging segmentation accuracy for your targets. In the 2024 BROTS Meningioma Radiotherapy Planning Challenge, we did not use multiple imaging because in radiation for meningioma, we often only require the post-contrast T1 3D native resolution image, and we don't really benefit much from the other series. So this was single image, single sequence, and we used a single label of just the gross tumor volume. So we did not have any of the other edema. Single label is going to be just having a binary mask of either 0 background versus a 1 of your target. For the BROTS Meningioma Radiotherapy Challenge, this was background 0 and then gross tumor target volume as defined by our protocol of 1. Multi-label is going to be when you have categorical mass, 0 being background, and then 1, 2, 3 can be enhancing tumor, non-enhancing tumor TOR, flare hyperintensity. When I was doing the Top Cow challenge, we had 13 different categories for each of the different vessels in the brain, and each of those have different accuracy metrics to follow. Subregions of interest, we kind of talked about this already, but the preoperative data set had the 3 different subregions of interest, and the radiation therapy planning one just had the gross tumor volume. When you're building data sets, it's important to be very particular about your inclusion criteria for your data. In 2023 preoperative data set, we define this as any benign neoplasm of the meninges defined in the chart in the preoperative setting, or it could have just come from radiographic pathologically consistent with meningioma, included the meningioma within the brain MRI field of view, and required to have all 4 of the series. So this was our inclusion criteria. We used the Epic Slicer Dicer tool. I don't know if any of you guys use Epic, but it's a very good research tool available to you that can provide you with a list of patients that meet a certain criteria that allows you to be, very intense in terms of figuring out the patients you can include in a study. In this case, we just listed all the patients at Duke with benign neoplasm of meninges, D32.0, and it gave us 1,300 patients immediately. When you're building data sets, important to figure out who you're going to include. So whether it's a single institution, multi-institutions, and if you do want to include multiple institutions of data, you need to make sure everyone has a IRB, at least in the United States, the Institutional Review Board, depending on similar thing in your countries. And then you need to have data use agreements to the host site. So when we hosted our challenge in 2023, Duke was the host site, and each of the different institutions had to sign an agreement with us to share their data in a standardized way. You also have to have some sort of data collection mechanism at each of the institutions, whether it be PACS, some other server, and then the DICOMs are going to be your initial files before you convert them to Nifty or some other format for processing of the data. When we process our data for BROTS challenges, we typically do start with the DICOM files, which are converted into Nifty. Nifty is just going to be a simple 3D file that is going to incorporate a intensity value at every 3-dimensional point in space. Technically can also have 4-dimensional imaging for Nifty files, but more commonly seen just as 3D imaging. It doesn't include any metadata. including patient information. It's really just those intensity values, but you can have separate nifty headers that have these metadata if you want. For our challenge, we use the FETS toolkit, which is available online, which co-registers the 4 series T1, T1C, FLAIR, and T2 into the SRI 24 Atlas space. Also performs 1 millimeter isotropic resampling and performs skull stripping, which is using the brain extraction tool, which is going to carve out a lot of the brain, as you can see here. There's a lot of different type of anonymization tools out there, and the brain extraction tool is what BROTS is traditionally used. Meningioma radiotherapy challenge in 2024 used something called the AFNI, which is developed by the NIH, which really just cuts off part of the nose below the eyes and kind of looks similar to the MRI D face you can see here in the image. It allows you to just have more anatomy, more inclusion of meningioma, which is an extraaxial tumor. So that way you can make sure you don't exclude that necessary anatomy. Some of the other data considerations to consider is if you do have multiple patients, images for one single patient, meaning that every 3 months they're getting a different scan. When you're building your data set splits, you want to make sure each of those single patients get put into the same split to make sure that you're not going to be testing on a patient's case that may have been seen in the training process, which would give you unfair, elevated results when in reality your model doesn't do that well. The data size is going to be pretty important. You want to have usually at least a few hundred cases if possible. Traditional data splits is going to be a 70% in your training bin, 10% in the validation bin, and testing is going to be about 20%. The larger your data set size is, the smaller you can make that validation and testing set. Usually you want a few dozen at least, sometimes a couple hundred in your testing set if you're hosting a challenge. Sometimes you have, data sets like Total Segmentator or the RTPNet with 25,000. And in these kind of data sets, you can have a very small percentage in your validation and testing set because you don't really need that many to show your models working. And when you have more in your training set, it allows your models to be more generalizable, so they work well when deployed at different institutions, different scanners, things like that. When I'm mentioning training, validation, and testing sets, what I mean by that is training set is going to be what the AI model is actually evaluating as it's undergoing its training process. It's the data that is continuously being evaluated and fine-tuned to try and craft a model that works very well for that specific training cohort. The validation set is going to be a not kind of external data set, but one that your model is going to be evaluating against every 10 epochs or kind of a training round through your whole training course. And depending on which validation performance is the best for that epoch's respective model is going to be saved as your final model to use. So sometimes throughout the training process, your model performance gets worse, but you kind of want to optimize that validation performance to make your final model, which is going to be used on a testing set, which is traditionally an external set of patients that we're not seeing at all in the training or validation cohorts to truly assess how well your model works when deployed elsewhere. Other information that's important to keep track of: age, sex, pathology, slice thickness, pixel resolution. These are all factors that a lot of different places are going to want you to keep track of when you report your findings in publications. Like we talked about before, you want to make sure you have IRBs for every institution. These are a few of the different institutions that were included in our projects. Yeah. Multi-institution advantage allows for more heterogeneity, different diseases, image parameters, image protocols, allows you to have bigger data set sizes, and this allows you to create generalizable models that work well elsewhere when you deploy your models. Disadvantages is just a lot more logistics, administrative work, data licenses, data use agreements can be a real pain, and it takes a lot of time to set this up. And if you don't have a lot of time, months, sometimes years to get all this in place, then you can't really do your project. For developing data sets, there's kind of a somewhat standard workflow that people go through to develop the ground truths for your data. And usually have to start out with doing a couple cases completely by hand before there's any model developed. In our case, we had 73 cases done completely by hand. And then we did a automated pre-segmentation. Well, I'll go through it a little more. So You want to define your labels during this manual segmentation process. It's good to go by literature. Certain protocols in the radiation world, RTOG and EORTC, specify how meningioma should be annotated. And when you develop your data sets, you want to follow these annotation protocols. Manual refinement is typically done with some sort of annotation tool. ITK Snap or 3D Slicer are free open source tools that you can use to quickly and accurately delineate your volumes for your data set. You can download them online if you want to try them out. MONAI Label is a new tool that came out last year, developed by NVIDIA, that is incorporated already into 3D Slicer. And what this does is kind of automates this whole annotation process where you start off doing a couple manually by yourself, and then you have it train a kind of simple model within the MONAI Label application, and it's going to create automated segmentations for you with certain uncertainties. We're going to refine those, and then as you refine them, it's going to iteratively retrain a model, and throughout that process, it just keeps getting better and better, so you can quickly develop very large data sets. After you do the initial manual segmentation, like I said, with the MONAI Label, you can do a pre-segmentation for your next cases, and this allows you to do a lot more cases quickly because you have a pre-segmentation to work off of instead of having to do every single voxel in space by yourself. You can see on the right that there are common errors that are seen with pre-segmentation models since they're trained on a limited data set, and you have to manually refine these errors to create your correct ground truths. This is an iterative process where you're retraining this pre-segmentation model to make it more and more accurate and reflective of the ground truth. Before you do a bulk refinement where you have thousands of cases with many different annotators all contributing their time and experience on these pre-segmented cases based on that initial model. Before these bulk refined annotations are sent to a this is just how we did our delivery of each of our files to all the different contributors. Total counts of everyone who contributed for our project. And so this is information we provided to each of our bulk refine annotators, so we're all kind of on the same page in terms of what protocol we're supposed to use and the tools that we use for doing our refinements. After all the thousands of bulk refined cases are performed, we have to make sure that they are ground truth eligible, and we have a fellowship trained Evan Calabrese neuroradiologist at Duke who approved every single case to make sure it is in line with our protocol. We split it up 70-10, 20% data breakdown as seen here. And then you have to upload your data to some data set repository. We use Synapse with the BROTS organization, which allows us to host and distribute our cases across each of the challenges for the BROTS segmentation challenges each year. I do want to point out for the meningioma radiotherapy study, we had just a single 3D T1C and native resolution with just a single label. Native resolution is not something that's seen frequently in automated segmentation data sets. This kind of was the first native resolution study that BROTS has ever done, and it compared very well to prior studies. Total Segmentator is a very impressive non-brain data set that included 104 different anatomic structures. It was one single institution's set of data across 1,200 different CT images that were resampled to 1.5 millimeters isotropically. And these were all for normal structures. It's just very impressive because they did have all the different clinical information available for each of these patients. They included all the different imaging parameter types, machine types, resolution types, and it's just a very comprehensive data set that should be replicated when you try and build whatever kind of data set for your studies you're trying to do. They had a very similar protocol to that, what we used with the BROTS organization, where they did their initial manual refine annotations and refined trained models on pre-segmentations, and then did their final ground truths based on these pre-trained models. It's just something to try and replicate in the future. They used a similar split, about 80, 10, 10%, maybe closer to 95, 5%, which is somewhat reasonable since they had a lot of cases. And they used a NORA medical imaging platform instead of ITK Snap. The models that they used in the total segmentator were very impressive. They had nice similarity coefficients up to 0.95, which is very good. In the auto segmentation world, we'll get to that in a little bit. If you do want to try out this code and kind of see how auto segmentation works for a non-brain study, they have a website that's easy to use. You just drag and drop Nifty or DICOM files onto their website, and it'll give you the automated contours in just a few seconds or minutes, depending on your internet speed. RTPNet is another impressive data set. They had 28,000 different cases with organs at risk, which are going to be normal structures. They also included target tumors, CTVs, clinical target volumes, and PTVs, which are prescription target volumes, with very high dice score 0.95, very low inference times, which means the model predicts in just under a few seconds. Yeah, so next I want to kind of give an overview of how deep convolutional neural networks works mathematically, and how you train AI models. So to begin, you first need to allocate your data into your training set, validation set, and testing set cohorts. The training set is going to be what your AI model is actually looking at as it trains, and that's going to be the only data it looks at as it's actively actually training, performing the calculations. Like we talked about earlier, the validation set is going to be that set that is continuously evaluated throughout the training process to figure out which model is optimal. Convolutional neural networks are a type of mathematical algorithm that tries to kind of replicate what the human brain sees in imaging. I would kind of use as a metaphor. There's a lot of different filters or features that allow you to see different shapes or patterns within your 2D or 3D imaging. Auto classification also uses these CNNs, and I'm going to kind of walk through the mathematics between a simple two-dimensional auto classification example. Auto segmentation is similar to classification, but after all this initial mathematics, it has another decoding part of its algorithm to recreate the segmentation based on the initial image input. In our simple case, we're just going to be using the number 9, kind of on a 2x2 or just a matrix here, two-dimensional matrix. You can see that background is going to be -1, and all of the positive ones is going to be what the user defines a ground truth as being number 9, and this is going to be our input data for each of the cases in this data set. You can see that sometimes the number 9, if you have the same matrix square, rectangle, is going to be shifted. And if you were to overlay that initial, foreground ones on the shifted 9, it wouldn't overlap the same. So how do you create an algorithm to figure out where the 9 is, relatively speaking, on your matrix? Sometimes 9s have different shape. You can see here that the user-defined 9 is very different from in the middle compared to on the right. So how do we figure that out using a model? And the way we do this is with convolutional feature maps, different layers, filters that depict different patterns within the number 9. At the top, you can see a loopy pattern. On the right is kind of a vertical line. On the bottom is this diagonal line, and use these things called filters or smaller matrices to figure out what this loopy pattern shape is. So here you can see that there's a -1 background in the middle, and these periphery represents this loop pattern. You can see for the vertical line, there's a bunch of ones in the middle representing how a 9 would incorporate a vertical line, and then you can have a diagonal line represented by these cross ones that are seen in number 9s. These are different filters, and kind of what I was just explaining, you can see these filters overlying our number 9. And when you are calculating the actual mathematics behind these convolutional neural networks, what you do is you take the dot product of your filter overlying every single different filter size within your matrix. So we're going to calculate the dot product here, and this is going to give us a -0.11. We'll repeat that process on the next set of 3x3 filter, and that'll give us this number. Then move it over, that'll give us this number. Repeat that process with the whole loopy feature matrix for our entire image, and then we're going to get a new matrix that's 1 unit smaller in each dimension. We're going to Repeat that process, like we said, to create the full feature map for that loopy filter. We're going to repeat that process across each of our different filters to generate a lot of different values. And ultimately, we use something called an activation function. ReLU, rectified linear unit, is used commonly, which is going to create nonlinearity. And the importance of this is to allow convergence of your model. If you don't have some sort of nonlinearity activation function, your models don't work as well. So by setting kind of a boundary of 0 and everything needs to be above that, it just allows your model to work better. Different loopy patterns. This is just an example showing what the different filter feature maps would look like. Similarly, just different feature maps. So the number 9 is going to have 3 different filters and 3 different corresponding feature maps for that initial layer. And after you perform this initial layer, this would be a feature map here on the left. You want to do max pooling, which is going to reduce the dimensionality even more. And max pool is going to be taking the maximum value from a certain size smaller matrix within that feature map. Then you would do a stride 2, which means you move your evaluation over 2 blocks, perform another max pool. If you want to just have a stride of 1, you could just go here, move it over 1, move it over 1, things like that. Repeat that process for multiple layers. As you move down smaller and smaller in size, you'll have different sort of filters and features. You just keep repeating that process for as many as your architecture supports. When you have these very large images, it allows you to do more and more filters and features. Ultimately, the last step is going to be flattening out one matrix to a single n by 1 matrix row. And this is going to be used to generate different weights for your numeric prediction to ultimately say this is going to be a, number 1, number 9, or like let's say number 9 or a number 7 or a number 6, whatever, based on the final values that your model sees. Once you have that final prediction that's made in your output layer, then you need to figure out whether or not it's accurate. And you're going to compare that prediction value to a ground truth value, which is going to give you a loss function value. So the AI robot is predicting number 9. I'm also predicting a number 9. So the loss function, if it's a perfect prediction, is going to be 0. In the 3D realm, we sometimes have different loss functions that give you a non-zero or 1 value, and you try and minimize this loss function across all of your different samples in your training set to build the optimal model. And your optimal model ultimately has this minimized loss function. This is just an example shown anatomically. AI is not always perfect. There are some errors in automated contouring. And it's seen, in here 1 to 35% of the time, depending on what anatomy you're looking at. The loss functions or metrics that we most commonly use are the dice similarity coefficient and Hausdorff distance. The dice similarity coefficient is when you're going to compare 2 different contours of the exact same structure, whether it be a human versus a human, or when we're training models, human versus the AI prediction. And the calculation for it is going to be the overlap region, number of voxels or pixels, divided by the area of the one versus the area of the other. This value is going to range from 0 to 1, where 1 is perfect overlap and 0 is going to be no overlap at all. Usually a value greater than 90 is very good. And then as you decrease, it's going to be worse performance. Hausdorff distance is another common metric that's used, which calculates the maximum distance between 2 points on your prediction or contours. 95% Hausdorff distance means we're not taking the maximum distance value, but the 95th percentile of that maximum distance. And this is, very good for determining kind of larger tumor, kind of spherical structures, that distance, to see how well your model works. Once you calculate these loss functions, you apply backpropagation, which is going to be a mathematical implementation to update the weights for each of your different filters or feature maps, layers in your AI model. And your final model is going to have a collection of weights for all of your different filters. And that's going to be the model that you can distribute to others. When we expand this number 9 to the 3D realm, we do the kind of the exact same thing. It's just going to be, instead of 2D matrices, we can use 3D matrices, and it's going to use just a bigger scale. And then unit is one of the most common 3D architectures for automated segmentation. And this is kind of the size of each of the images and filters layers that they have, and kind of each of the steps for their encoding and decoding phases. I'm not going to go too into detail about the 3D architectures now. That's kind of even beyond my expertise, but this is one that's commonly used. So if you want to get involved with any automated segmentation challenges, it's definitely something I would encourage you to try doing. They can be very fun and very educational. Mackay is going to be the big conference each year that hosts a lot of the automated segmentation challenges. We personally, with Brats, contribute, I think this year, up to like 12 different challenges. And a lot of these different challenges for Mackay are going to be posted in the early spring, very rarely early summer, usually in April. And I would recommend that you check out their website over the next couple weeks to see what challenges are being released that you could participate in. The results of each of the challenges are announced at Mackay, which this year is going to be in Korea at the end of September. Last year, we were in Morocco in middle of October. The different tasks that the Brats organization's doing this year are the segmentation ones I mentioned earlier, as well as generalizability of segmentation across different tumors, where you have a training data set that has a lot of different tumors and you don't really know the pathology of them, but you want to train one model that generalizes well to all of the different pathology. And this could, potentially have good clinical use moving forward. Global synthesis, local in-painting challenges. Global synthesis is what I was talking about earlier, where you may be missing a certain sequence and you have to artificially synthesize it. Local in-painting is when you are creating a artificial structure within a image. And one of the teams called Faking It at the Meningioma Challenge last year, and I think they did it for some of the other segmentation challenges as well, created extra data to train on by performing in-painting of actually artificially introducing tumors into normal brain scans. And by doing so, it allowed them to look at some of the surrounding anatomy around brain or synthesize brain tumors. And they did very well in many of the challenges because they had this extra data to train on. Some of the other ones is doing pathology now for brain tumors and tumor response after therapy. Grand Challenge is one of the websites that hosts a lot of these challenges. They have a very standardized process of providing information about many challenges, providing links to data sets, and they have an extremely standardized process for uploading your algorithms in Docker files or Docker containers, and using the embedded metrics that are already built into the website to actually deliver metric results to you in real time within just a few minutes for your model, so you can continuously evaluate your performance. I really like Grand Challenge a lot, and I'd recommend in a couple weeks or maybe a couple months checking out what they have, because there's not a whole lot of challenges there right now, since a lot of them are getting released in these next few weeks. If you do want to participate, you have to choose a good framework that's easy and effective to use. I personally am very familiar with the Auto 3D Seg, which I first found out about in the 2023 Brats Challenges from Andrei Marinenko. He's an NVIDIA engineer who kind of helped develop this Auto 3D Seg framework that kind of has an end-to-end process for analyzing the image data in your training data sets, figuring out all the different parameters and hyperparameters that would make this model effective. And then you can train with either a SegResNet or a SwinUNet transformer, which are different kind of model architectures within the Auto 3D Seg framework. And I think it's just very easy if you're trying to get started with automated segmentation to use Auto 3D Seg, since it automates so much for you and it kind of just works. If you do want it to work, though, it's kind of required to use Linux. I personally have a desktop that I tried using Windows and I couldn't get it to work due to a lot of environment configuration issues. But if you learn how to dual boot your computer into Windows and Linux, then you can load into Linux and use their operating system and environments to effectively use Auto 3D Seg. NVIDIA GPUs are, I think, pretty much required in a lot of automated segmentation at the consumer level due to something called CUDA cores, which allows for GPU accelerated training. I haven't seen any advanced microsystem devices, AMD GPUs allowing for automated segmentation training. I don't work for any company. I don't want to, tell you one can or can't work, but I just personally think NVIDIA GPUs are kind of required. VRAM is going to be how much data you can hold in your training models. So more VRAM you have allows you to have bigger parameters, more complex model development. And I think it's recommended to have about 16 gigabytes for a lot of the modern automated segmentation models. I personally did the Top Cow challenge with 11 gigabytes of VRAM, and that was me trying to max out a lot of the different parameters for more layers, deeper neural networks, smaller batch sizes, which allows you to pass less amount of information through your model each time. Or sorry, bigger batch sizes allows you to pass more information through each time so you can train faster, so you can have these more complex architectures train quicker. And as you increase the VRAM size, it allows you to train more data quickly. If you do want to submit your model on grandchallenge.org, they utilize Docker containers, which is a way to compartmentalize all of your code and environment in a easily shareable and distributable format. Brat's cluster of challenges historically has used something called ML cubes, which is kind of an extension on Docker containers. That's been a bit tricky for a lot of teams. So this year we're seeing if we can make a last minute change to using Docker containers like the Grand Challenge organization challenges do instead of the ML cubes, but that's kind of still to be determined and announced over the next few weeks. So yeah, that's kind of all the information I wanted to run through. And now I have a few quiz questions to go. And Marufa, do you have a specific process you want me to do the quiz questions, or just kind of let people like type in the chat? Or
Oh, I think they
Okay.
could type in chat. Yeah, that should
okay,
work.
sounds great.
Yeah,
So
Yeah.
but good job. We already have series of questions lined up here that we really like you to share your thoughts on them. Specifically, the number one here is that
Oh, Maruf, one
we
second. Maruf, one second.
okay.
So Dominic wants to do a little bit of quiz himself, and then we go into the Q&A.
Oh, okay. All right, let's
Yeah.
have the quiz.
I'm good with whatever. We can do the quiz first, I guess. These are hopefully easy questions for everybody. All right, so the first question will be, when preparing data sets for automated segmentation development, what's a good percentage typically allocated for a testing data set? And testing is going to be what you are kind of using to externally validate the performance of your model. Yeah, so a lot of B's, 20%, 30%. Yeah, I'd go with B, 5 to 20%. That's going to be what we most commonly see. If you get really, really big data set sizes, tens of thousands, I think it would be okay to reduce that down to, less than 1%, definitely less than 5%. If you unfortunately have very small data set sizes where maybe it's only a couple dozen cases, you kind of need to have a higher allocation to your testing data set, maybe 50% or higher. And the reason for that is because you need some sort of statistical power in your metric analyses, just so you have a couple dozen cases in your testing data set. There's been a lot of models over the past couple years, not so much in medical imaging, but in other kind of uh, image AI, where you can have maybe a one look image, so it only sees one training case. And based on that one training case, it's very good at extracting a lot of different features and allows you to make very accurate predictions. So that might be a case where you can have, a training size of one and a testing set of a lot. There's a medical imaging data set and model that was released about a year and a half ago, just under a year. It was like May of last year, called Segment Anything model, which is for 2D images, where they claim you can segment any anatomical structure in the body based on their pre-trained model. And this would be another kind of case where you can have a larger testing set with unseen anatomy and unseen data compared to your training set. So yeah, good job, everyone. B is, I think, the most appropriate answer for the majority of cases. All right. So second question, what does the dice similarity coefficient measure in the context of automated contouring? Yeah, pretty much everyone's getting it. This is a, pretty straightforward question. The answer is kind of in the question, but similarity between two contours of the same anatomical structure. And it doesn't necessarily need to be between a human and a machine. It can be between two humans. It can be between two machines. The important takeaway is it's just a mathematical calculation of uh, 2 times the overlap region divided by the region A volume or area plus the region B volume or area, and it ranges from 0 to 1, 1 being perfect. So good job, everyone. What purpose does the ReLU activation function serve in deep convolutional neural networks? Okay, seeing a couple different answers here. Um, couple more coming through. So the answer is B. What the ReLU function is that kind of flat, and then it's going up at a linear slope to introduce nonlinearity into the network. And the purpose of this is to allow that calculated feature map to only have positive values. And this introduces nonlinearity into each of the different layers in your network to ensure that your model is able to converge. Um, when you don't have nonlinearity in your network, models have a hard time converging or figuring out an appropriate single answer or prediction in your model training process. So that's why we use this ReLU rectified linear unit activation function. Um, Calculating the loss function is what we use the dice similarity coefficient or Hausdorff distance for, and the loss function is going to be what we're trying to minimize. So in practice, a common loss function is going to be 1 minus the dice similarity coefficient. So if your model is able to predict a label that is near perfect agreement with the ground truth that is evaluated with the dice similarity coefficient, you might have that dice of 0.95. So your loss function in that case is going to be 1 minus 0.95 to give you a value of 0.05. And that is going to mean that you have very good model right now, and you want to back propagate those weights back through your network to try and have this low loss function. Does that make sense, everyone? So. All right, cool. All right, so what is one key advantage of multi-institutional data sets for automated segmentation compared to single institution data sets? Yes, pretty much everyone's getting this one. Increased heterogeneity of disease and imaging parameters. This is extremely important when you're trying to build a model that is very generalizable to new study protocols, new machines, new anatomy, and by having a large amount of diverse cases in your training sets, it allows your model to see a lot of different features, anatomy. So when it is trying to predict on an unseen case, if it's seen a similar anatomy case before, then its model weights are going to be able to accurately predict the appropriate label prediction. What we do with the FETS, Federated Tumor Segmentation project, is incorporate images and labels from dozens of institutions. The FETS 1.0 model had 71 different contributing institutions. And by incorporating all of this multi-institutional data, it allows that single model to deploy very well to a new institution that may have an overlapping scanner or image protocol to one of those 71 institutions. So it's seen similar data before. I didn't really talk about it as much as I had hoped, the federated tumor segmentation process, but what that is when you have one central institution kind of being the host site for a federated model, and during each epic or round of that convolutional neural network model training, you are having each institution evaluating just its data with the current model weights from everyone's contribution to a single model weight, and updating its loss function calculations based on their single institution's data for that current epics model. And when it sends all of the different model weights back to that central host site, more calculations are performed to optimize the model weights, which are then redistributed for the next round to each institution. And everyone as a whole kind of builds this one single optimal model throughout the training process. And I think federated learning and training is going to be one of the most important and funded and used training processes over the next few years across different disease sites, since it allows us to have this large amount of data from many institutions. It's just hard right now because it's expensive and there's not as much infrastructure due to a lot of the complexities, both logistically and data collection wise, that are needed for these federated models. But yeah. All right. Next question, which of the following annotation strategies involves continuously refining an initial automated segmentation model based on expert feedback? This is something that the MoneAI label tool within 3D Slicer is very good at. Yep, everyone's getting it. It's iterative retraining. And what this allows you to do is have these simpler models assist you in the ground truth development for each of your labels within your training data set. Manual segmentation alone would take a very long time to create ground truth labels for every case, since it can take hours for, full post-operative glioblastoma, since there's many slices with, a very large volume that needs to be annotated. In our analyses of the meningioma and glioblastoma challenges and data last year, there was, I think, like sometimes 600,000 voxels in one case that had positive labels. And if you had to manually segment all 600,000 voxels, it takes a very long time. One thing that the cluster of challenges for BROTS this year is actually doing is having 25 test cases undergo manual segmentation twice by certain providers. And the purpose of this is, one, to see how long it actually takes to do manual segmentation from scratch. And I applaud these, radiologists for putting in their efforts for this. And it's also going to show whether or not a manual segmentation from scratch ground truth is reflectively accurate compared to one that was ground truth based on a manually refined pre-segmentation, just because of the amount of time and tiring that humans can undergo while creating these ground truths. So iterative retraining is very helpful. All right, last question. What specific image pre-processing step involves removing non-brain tissue from MRI scans? Yeah, everyone's getting it. So skull stripping with the brain extraction tool is the one that has commonly been used before. Different anonymization tools called, the AFNI from the NIH or MRI deface, MRI reface, PyDeface. There's a lot of different anonymization tools. And the reason we do this is, one, to just limit the anatomy seen to the important structures. So your model has less noisy data to try to learn from, and it can just focus on what's most important. It's also important when you're distributing data publicly to make a best effort at reducing the chance of identifying the actual patients that were used in the study. And whenever you use these anonymization tools, and especially the very intense skull stripping, it reduces the chance of re-identification to near zero for skull stripping. Co-registration to the SRI-24 Atlas is another step that is used to ensure that all 4 series, T1, T1C, FLAIR, and T2, are all overlying each other within a atlas space. And what an atlas space is going to be a certain number of voxels that is consistent between all your cases in your training set. So I think SRI-24 is like 240 by 240 by like 151 voxels, or voxels in that specific atlas space. Skull isotropic 1 millimeter resampling is when each of your voxel is going to be a 1 by 1 by 1 millimeter voxel in real space. Native resolution, which we used in the Broad Meningioma Radiotherapy Challenge, just used the native resolutions, which are going to be sometimes 1, sometimes non-1 image sizes. So that's about it for today. Thank you guys very much for having me. I had a wonderful time speaking with all of you, and thank you, Ruth, Fedona, and all the other organizers for putting this together and having me. And I'd be very happy to take any questions from anyone.
Okay, thank you so much, Dominic. We really appreciate you too. You've done a just work in trying to give us a crash course on artificial intelligence and also radiation oncology, both of which they are like really big field on their own. We sincerely appreciate you, and we hope that when next we invite you to give a talk, you surely answer. Um, Before we call it a day, we have some series of questions piled up here, but I would like to start by asking, segmentation is one of the key things we do in radiation oncology, at least coming from my own medical physics background. And we've seen out over the years, we've come from the normal computing mode, such as thresholding for long window, the likes, so we've used it for organ at risk. And nowadays we have some AI methods that is able to delineate our target volumes for us. Noting that, where is the next big thing? Where is the next big involvement that you think AI is going to revolutionize radiation oncology that we are yet to see, but you have an inclination that AI is probably going to solve this problem for us in the next few years?
Yeah, I love that question. It's a great question. Thank you for asking. And what the question was is kind of where the direction of AI is in the radiation oncology realm over the next few years. Like you mentioned, auto contouring has been historically used in radiation oncology, and atlas-based methods, which don't involve so much AI algorithms, but kind of just overlying relative anatomy from an initial case, have been used for 20 plus years now. So automated contouring at a simpler level has been around for a long time, but in recent years, automated contouring has moved towards adaptive radiotherapy planning. I think the variant ethos system was kind of the first major stakeholder in this that came out around 2020, 2021. And as I mentioned earlier, the adaptive radiation planning allows a patient to have a new treatment plan developed as they're on the table for that specific treatment on that day. And the way the workflow works is a halcyon tomotherapy radiation machine acquires a CT scan of better quality as the patient's on the table ready for treatment. The new CT image is going to be automatically segmented, and based on those quick automated segmentations, a new plan can be developed instantaneously, just about 1 to 2 minutes. This new plan can then be reviewed by the on-call or reviewing physician on site, and the reviewing physician can decide to either use these new beam arrangements for the new optimal plan, or it can disregard the new information from this new adaptive plan and just use the original plan with the original beam arrangements and dose field dose calculations. And adaptive replanning has been shown to reduce toxicity in a lot of patients, especially in the head and neck world, where there is a lot more side effects in terms of skin damage, long-term taste loss, dryness, a lot of soft tissue fibrosis. And it's used a lot in the pelvic area, a lot of abdominal cases. I haven't seen it used as much for brain, since brain typically uses a stereotactic radiosurgery machine like an Edge with variant software, or Gamma Knife, and the multi-leaf collimators with these, stereotactic radiosurgery machines are a lot smaller, so it allows for more precise measurements. So I think adaptive replanning is the number one
Is the
area.
way to go. Yeah, thank you so much for that. Then also we have a question here from GDOK. He's trying to get clarification regarding brachytherapy and radiopharmaceuticals. He believes it's based on their half-life. Do you want to give some thoughts to that?
Yeah, absolutely. I actually took out some of my slides for brachy. Now I wish I left them in there, but let me see if I can pull them up for you real quick. So I can kind of give a bigger overview on brachy for you. But the question is just kind of giving a more in-depth discussion on how brachy works. And let's go from here. So what brachytherapy is a way to deliver radiation from inside of the body, usually during surgery or in a brachytherapy procedure itself. A source is placed right next to the tumor, and it can either be activated for a few minutes with something called high dose radiation, HDR, or it can be a seed that's implanted, such as prostate seeds that are left in there for many days. Well, they're left in there forever, but they're active for a few days as the half-life time is being exceeded, and the amount of emitted radiation from that source is, exponentially decreasing over time. Another example of brachytherapy is during a intraoperative case, sometimes during the actual surgery in breast or rectal. A radiation oncologist will work with the surgeon to place a source right next to the postoperative site to give a dose of radiation in the immediate aftermath of the surgery to try and cure from any microscopic cells that could still be there. The image here is showing kind of a brachytherapy procedure where we're placing different needles into the uterus with a tandem and ovoid structure method. In the bottom right, the top right is going to be when we're placing needles into the prostate. And when you place these different sources and certain geometrical patterns within your target organ, it allows you to distribute the dose in a very conformal fashion, because no dose is coming from outside the body, going through the skin, going through the fat or muscle. It's all concentrated just in the organ of interest. So it's a very good way to limit toxicity. A lot of the more conformal IMRT, stereotactic body radiation therapy techniques recently have kind of replaced brachytherapy in a lot of different centers, because it's just logistically easier to do with comparable side effects. But that's kind of a little more information on brachy.
Okay. Yeah, thank you. Then he also wants to know, when exactly are organ at risk and target volume delineation done? Are they done during the CT simulation?
Yeah, so right after a CT simulation is done, those images are uploaded to our software. At Duke, we use something called ARIA or Eclipse, and using ARIA, we create the 3D volumes from that CT simulation over the next couple of hours or next couple of days. It's not something that's done immediately. They need to be processed, uploaded, those images before we can actually draw those volumes. A lot of the organ at risk volumes nowadays are done automatically or by a dosimetrist. So the actual providers aren't always the ones doing the organs at risk. They might just review them and check them off.
I see, great. Yeah, then we also have a question from Seth. He's asking, in the MRI image segmentation, what model will be best to use, a 2D or 3D model?
For MR images, was that?
Yeah, for segmentation, he's asking if to make use of 3D model or 2D model. Like, you know, the network architecture and the input images they took, some will take it slice by slice, some will take the 3D object image as a whole. So do you want to
Yeah,
quickly
that's a
respond to
great
that?
question. It's a very interesting question because the segment anything SAM model that came out last year is a 2D model, but I haven't seen any literature or studies that have tried to expand that very, very accurate 2D segmentation anything model to the 3D realm. Besides that one case, though, I would say that 3D mathematical models that use convolutional neural networks or transformers in a 3D space work better than trying to predict 2D layers and compile them all at the end. So a true 3D model, I think historically has worked better. And in our broad challenges, everyone uses 3D models for the top performing teams. So NNUnet's one of the most popular, SegResNet, another very common one, SwinUnet, Transformer, another common one. Yeah.
Yeah, yeah, and then just to add a little to what you just said, my experiences, I've realized that 3D model generally require high computational computing resources, whereas if you are working with 2D images, you can still make use of the computing resources available to you and still get your segmentation results output. Okay, so that's it. We do not have any further question. We really thank you so much for making it a day with us. And to all our participants as well, thank you so much for being part of this seminar series today. We hope you make it a day with us next time. Before we call it a day, I'll quickly like to ask Marina and Julie, do we have any announcements?
Yeah, thanks so much everyone for attending, and thanks Dominic for such a lovely talk today. So we will have the next Own Your Future Mentorship seminars that will occur next month. And this will be on I'm just checking the date for the last Monday of the month. It will be the 26th of May. So just watch out on WhatsApp and X and LinkedIn for the next poster. And the recordings will be available on YouTube for you to watch as well. So I've sent a link in the chat, but I will repost these on all our social media channels as well.
All right. Thank you so much, everybody. Do have a lovely day. See you next month. Bye.
Thank you, everyone. Have a great day.
Thank you, Dominic. Thank you, everyone.